Imagine sending a patient to brain surgery to save their vision, knowing that the data guiding your scalpel is, well, fundamentally flawed.
It is a terrifying thought. I mean, we are talking about permanent surgical interventions on the human brain here.
Welcome to the weekly Neurology Deep Dive. This program is produced by Amar Gavan. And before we get into the details, we absolutely must provide our mandatory disclaimer.
Absolutely essential.
This deep dive is for educational purposes only. There is absolutely no commercial goal behind this program. What follows is strictly a summary of the published literature, and we highly recommend that you read the full paper we are about to discuss to inform your daily clinical practice.
Exactly. I mean, nothing replaces reviewing the primary literature yourself, especially with stakes this high.
So today we are exploring a paper titled Stenting versus Shunting in Sight-Threatening Idiopathic Intracranial Hypertension, Genuine Equipoise.
And that paper was authored by Susan P. Mullen and colleagues, published in Practical Neurology in the year 2026.
Usually, when you talk about a medical diagnosis or a surgical intervention, you expect a lot of precision.
You really do.
Like, think of a ruptured appendix. The imaging shows the inflammation, the surgeon points to it, and the surgical path is undeniably clear.
It is entirely binary. The organ is failing, so you simply remove it.
But when you step into the world of neurology and specifically managing sight-threatening idiopathic intracranial hypertension, well, that comforting precision just vanishes.
It completely evaporates. You are looking at a diagnostic and surgical landscape that is incredibly murky.
For the neurologists out there who are short on time, let us provide the bottom line practical summary of this paper right at the top.
A great idea.
For patients with sight-threatening idiopathic intracranial hypertension, there is currently no high-quality randomized data proving whether cerebrospinal fluid shunting or dural venous sinus stenting is the superior procedure.
None at all. Though both interventions do effectively lower intracranial pressure and reduce papilledema.
But until new randomized trials conclude, your surgical candidacy decisions should never rely solely on visual field testing.
That is a crucial takeaway. Instead, decisions must include objective optical coherence tomography, evidence of moderate to severe papilledema.
Furthermore, clinicians must ensure these patients are genuinely medically refractory rather than simply being undertreated by the healthcare system.
Which happens far too often, unfortunately.
That brings us to the terrifying tension of this paper. Why, after decades of performing these exact procedures, are neurologists and neurosurgeons essentially flying blind when choosing between a shunt and a stent to save a patient's vision?
It is a profound question. We are performing invasive brain surgeries, yet the high-quality data guiding those choices is largely absent.
Which is alarming.
It becomes even more alarming when you look at the mechanics of what is actually happening in the operating room.
What do the numbers look like?
Well, in the United Kingdom, for example, between about 7 and about 8% of people living with idiopathic intracranial hypertension require a surgical procedure to preserve their vision.
Let's unpack this. What do those interventions actually look like on the ground?
When we break down the intervention rates, cerebrospinal fluid diversion is by far the most common. It accounts for about 6% of patients.
And mechanically, that involves drilling into the skull, correct?
Exactly. Or accessing the lumbar spine to place a literal plumbing bypass. It is a tube that constantly drains excess fluid away from the brain.
And what about the other procedures?
That is followed by dural venous sinus, stenting at about 1%. Stenting is completely different.
It is more of an endovascular approach.
Precisely. It involves snaking a catheter up into the brain's venous system and deploying a metal mesh scaffolding to prop open a narrowed vein.
Which allows blood to drain faster and indirectly lowers the pressure.
Exactly. And finally, we see optic nerve sheath fenestration, also at about 1%. That involves cutting tiny slits directly into the sheath surrounding the optic nerve to release the fluid.
So those numbers show a massive historical preference for cerebrospinal fluid diversion.
They certainly do.
But recently, you see this massive surge in enthusiasm for dural venous sinus stenting. Clinicians are incredibly excited about it.
They are. But this paper points out that the enthusiasm might be built on incredibly flawed evidence.
Wait, really? Flawed in what way?
Well, the authors specifically call out the RiverStent trial as a perfect example of how skewed data influences clinical practice.
Tell us more about that trial.
So this trial evaluated a specific intracranial stent to treat symptomatic venous sinus stenosis in idiopathic intracranial hypertension. But it's an single-arm, open-label study.
Single arm meaning they did not randomize patients against a control group.
Exactly. To establish the safety and efficacy of their stent, the investigators chose to compare their outcomes against an uncontrolled historical data set.
A historical data set of patients who underwent cerebrospinal fluid diversion.
Yes. And here's where the data gets heavily manipulated.
I am bracing myself.
The fatal flaw is that this historical data set had a notoriously high complication rate of about 52%.
About 52%. Oh my goodness.
I know. We were talking about data from an era where shunts failed frequently, became infected, or overdrained.
Claiming that dural venous sinus stenting is vastly superior based on that historical data is, well, it is like claiming a brand new smartphone is a technological marvel strictly by comparing it to a 15-year-old flip phone.
That is a brilliant analogy. You are entirely ignoring modern alternatives.
Because if you look at recent well-conducted studies using optimized modern cerebrospinal fluid diversion protocols, the revision rate drops significantly, doesn't it?
It absolutely does. It drops to about 11%.
So by comparing a modern stenting procedure to an outdated, highly complicated shunting dataset, the River Stent trial likely overstated the efficacy of stenting.
And its relative safety, exactly.
Yeah. This publication bias strictly affects you, the neurologist listening to this, in your daily clinical decision-making.
It absolutely does. If you read a paper claiming a 52% complication rate for shunts versus a much lower rate for stents, you naturally refer your patient for a stent.
But the underlying comparison is fundamentally broken, which leads to the obvious question. If we know the current data is this flawed, why haven't we just run a proper head-to-head randomized trial to fix this?
The answer comes down to a strict clinical research concept called genuine equipoise.
Genuine equipoise. Let us define that for the listeners.
In clinical research, genuine equipoise is the requirement that the investigators and the medical community at large have no clear preference between the treatments being evaluated.
So if a doctor secretly believes one treatment is definitively better, they cannot ethically randomize a patient.
Exactly. They cannot put a patient into a trial where they might receive what the doctor considers the inferior treatment.
We have actually seen massive trials fail because of this exact issue, haven't we?
We have. The paper mentions the surgical idiopathic intracranial hypertension treatment trial.
Then what happened there?
That trial attempted to evaluate cerebrospinal fluid shunting versus optic nerve sheath fenestration versus medical therapy alone.
And it failed to recruit enough patients.
It did, and it was ultimately shut down. The authors of our paper argue this failure was driven by a complete lack of investigator equipoise.
And that was largely because of the inclusion criteria, correct?
Precisely. The trial investigators were required to randomize patients with severe impending vision threat into a medical-only arm.
How severe are we talking?
We are talking about patients with visual field mean deviations, ranging from -6 decibels to -27 decibels.
For the clinicians listening, let us contextualize a visual field mean deviation of -27 decibels.
It is severe.
That is not just a subtle blurring of the peripheral vision. That patient is practically living in the dark.
Exactly. They are experiencing severe tunnel vision or near total blindness.
Neurologists and neurosurgeons simply refuse to risk a patient's vision by withholding surgery when the structural damage was already that profound.
It makes complete clinical sense. You do not gamble with a patient's remaining eyesight just to satisfy a pristine trial design.
But this brings up another massive controversy highlighted in the paper, which is how we actually define a surgical candidate in the real world.
Yes, the terms fulminant and medically refractory are thrown around constantly to justify rushing a patient to the operating room.
They are used clinically all the time, but with very little validation.
Exactly. Let's look at fulminant disease first. It is classically defined as a rapid escalation of the clinical syndrome requiring surgical intervention within 4 weeks of the initial diagnosis.
However, the authors note that this strict 4-week time limit is often entirely too rigid.
It is. Rapid sight-threatening deterioration can occur at any stage of the disease.
So strictly adhering to a time-based criterion might delay urgent, necessary care for someone who has had the disease for 6 months but suddenly deteriorates.
Which is incredibly dangerous. And the second label is even more problematic.
The medically refractory label. I completely agree, and I want to push back on this label.
Please do.
This paper raises a critical question for you, the practicing neurologist. Are you rushing to perform surgical interventions and hastily labeling patients as refractory simply because our healthcare systems are failing them?
That is the crucial question.
Are they truly refractory to medicine, or have they just not had fast enough access to proper weight management services?
Exactly. Or perhaps they have not been given adequate doses of modern targeted headache treatments for a long enough duration.
It feels like a systemic failure in how we manage this disease globally.
You have hit the nail on the head. The authors argue that true medically refractory disease would be far less common if patients were optimally managed from day one.
Because there is overwhelming evidence regarding weight loss, isn't there?
There is. Weight loss correlates directly with a reduction in intracranial pressure and a dramatic decrease in the headache burden.
Mechanistically, adipose tissue is hormonally active.
Precisely. It actively drives the systemic inflammation and the pressure dysregulation.
So if a patient is labeled refractory but has never engaged with a successful, medically supervised weight loss intervention,
Or has never received modern targeted therapies at therapeutic doses.
we are failing them. Surgery should be reserved strictly for true impending sight loss, not as a shortcut for inadequate medical management.
I could not agree more.
So if we agree that rushing to surgery is a systemic failure, the immediate question for the neurologist sitting in the clinic is, how do you actually know when your patient is truly on the brink of going blind?
That is the million-dollar question.
If we are deciding when to drill into a skull or place a stent, the exact measurements you use to make that high-stakes call are everything.
They absolutely are.
For years, the gold standard has been the Humphrey visual field mean deviation. But this paper argues that relying solely on this measurement is incredibly dangerous.
It is deeply problematic for several mechanistic reasons. The widespread assumption is that the visual field mean deviation should strictly guide clinical decision-making.
But think about how the test physically works.
Exactly. First, peripheral visual field constriction is a hallmark of increased intracranial pressure. Yet standard automated visual field tests typically only sample the central 24 to 30 degrees.
So you are entirely missing the very periphery where the damage often starts.
You are. And second, the peripheral data points on these tests are known to be notoriously unreliable.
But beyond the hardware limitations, you have to consider the human being actually taking the test. The paper explicitly mentions cognitive impairment.
Cognitive impairment is a fundamental feature in patients suffering from idiopathic intracranial hypertension.
High intracranial pressure causes significant brain fog, pain, and profound fatigue.
And visual field testing is highly subjective. It requires the patient to sit in a dark room, maintain absolute focus on a central target, and press a button every time they perceive a tiny flash of light in their periphery.
If a patient is cognitively fatigued and their head is pounding from the pressure, they will inevitably miss those peripheral flashes.
Exactly. And that artificially worsens their mean deviation score.
You could end up sending a patient for invasive brain surgery based on a worsening visual field that is actually just a reflection of their fatigue and poor concentration.
Rather than the physical death of the optic nerve.
So, how do we move away from subjective button pressing to something undeniable?
The new trial group has established a pragmatic, strictly objective standard. The standard requires objective structural evidence of damage.
Meaning candidates need a clinically documented Frisson grade of 3 or higher?
Exactly.
Let us remind ourselves what a Frisson grade of 3 actually looks like under the ophthalmoscope.
We are talking about the borders of the optic nerve being completely obscured, with the elevation of the nerve head extending into the surrounding retina.
It is a visibly angry, swollen nerve.
Furthermore, that Frisson grade 3 must be paired with objective proof of increasing papilledema on optical coherence tomography.
Which bounces light off the retina to give us micrometer-level structural data.
Precisely. Clinicians must specifically look at the retinal nerve fiber layer thickness, the total retinal thickness, and the optic nerve head volume.
The images provided in the paper are incredibly striking. They show optical coherence tomography scans of patients before and after these procedures.
And the change is rapid.
You can see a massive reduction in total retinal thickness by day 1 and day 10 after either a shunt or a stent, alongside corresponding improvements in the visual fields.
It proves the plumbing definitely works.
But this raises a fascinating practical dilemma for you in the clinic. How do you weigh this pristine optical coherence tomography data against a patient's subjective complaints?
It happens all the time.
Picture it. A patient sits in your office, highly distressed, and says, "My vision's getting worse, the headaches are unbearable."
But you look at the optical coherence tomography, and the retinal thickness is perfectly stable.
Exactly. Who do you trust?
You must trust the objective data. If the optical coherence tomography shows stable retinal nerve fiber layer thickness and stable total retinal thickness, the optic nerve is not in immediate danger of irreversible structural damage.
Subjective symptoms, especially headaches, can fluctuate wildly.
They absolutely do.
Yeah.
They do not always correlate perfectly with the actual intracranial pressure in real time.
Operating based solely on subjective complaints or flawed visual field tests, without optical coherence tomography confirmation of worsening papilledema, exposes the patient to massive risks.
Massive surgical risks without a guaranteed structural benefit.
But focusing so intensely on the optic nerve creates a massive blind spot in how we view the patient as a whole.
It really does.
We spend so much time focusing on this localized plumbing problem, like draining fluid from the ventricles or propping open a narrowed vein, that we forget what is happening to the rest of the body.
That is perhaps the most vital point of the entire paper. Lowering intracranial pressure with a stent or a cerebrospinal fluid shunt does absolutely nothing to cure the underlying systemic disease.
The paper delivers a stark reminder regarding the metabolic phenotype of these patients.
This condition is fundamentally characterized by truncal adiposity, adipocyte dysfunction, hyperandrogenism, and severe insulin resistance.
And the cardiovascular risk attached to that metabolic phenotype is staggering.
It is. The paper notes a twofold increase in the risk of cardiovascular events compared to weight-matched peers.
So it is not just about a patient being generally overweight. It is a highly specific, dangerous metabolic profile that actively drives systemic disease.
And the systemic morbidity of idiopathic intracranial hypertension remains completely untouched by our mechanical plumbing procedures.
A stent may save the vision today by structurally allowing better venous outflow.
But it does not stop the patient from suffering a severe cardiovascular event a decade later due to their untreated insulin resistance and adipocyte dysfunction.
Which is exactly why gathering high-quality evidence for the procedures we do perform is so urgently necessary.
Absolutely. And that is why the paper introduces the upcoming idiopathic intracranial hypertension intervention trial.
Funded by the National Institute of Health Research in the United Kingdom.
This trial is monumental for the field of neurology. It is designed to finally randomize patients presenting with sight-threatening disease into two distinct arms.
Cerebrospinal fluid shunting versus dural venous sinus stenting.
Exactly. By forcing genuine equipoise and relying on objective optical coherence tomography data for inclusion, it will definitively answer which procedure offers better clinical outcomes.
As well as fewer adverse events and superior long-term cost-effectiveness.
Notably, optic nerve sheath fenestration was completely excluded from this new trial.
The paper explicitly states this was due to a sheer lack of available surgeons with the required expertise to perform it within the United Kingdom.
It is a stark reminder of how local surgical expertise heavily dictates the practical options available to you and your patients.
To summarize everything for the practicing neurologist, currently, neither stenting nor shunting is definitively proven superior by high-quality randomized data.
Though both procedures successfully lower intracranial pressure and reduce papilledema rapidly.
In your daily practice, do not rely solely on subjective visual fields to rush a patient to surgery.
You must demand objective optical coherence tomography, evidence of severe worsening papilledema.
Finally, ensure that systemic and medical management, including aggressive weight loss interventions and targeted headache therapies, have been truly maximized before you ever label a patient medically refractory.
A fantastic summary.
Here is a final thought to mull over as you head back into the clinic, building on the systemic nature of this disease.
I love a good provocative thought.
If idiopathic intracranial hypertension is fundamentally a severe metabolic condition carrying a twofold cardiovascular risk, will the future of neurology eventually view these mechanical plumbing procedures as archaic stopgaps?
Drilling holes for shunts and expanding veins with stents.
Exactly. Will we one day replace them entirely with advanced, targeted metabolic therapies that reverse the condition at its cellular root rather than just patching the pressure valve in the brain?
It is entirely possible, and frankly, it is the future we should be aiming for.
Thank you for joining us on this weekly neurology deep dive. Remember to read the full paper to enhance your clinical practice.